Depending on the age, you suspect these abnormalities. If it's quite a young patient, you should always suspect hookam, myocarditis, or conduction abnormalities. Between ages from 20 above, you should mainly suspect CAD, myocarditis, or hookam. Next. Now the question arises, should he go to a cath lab? Yes, he should definitely go to a cath lab. Even if there is no evidence of ACS, you need to exclude a chronic heart disease or a stable heart disease which has become unstable. Because sudden cardiac death may be the first indication of coronary artery disease. Now the question comes, if he should go to the cath lab, does he need to do it right now? Next. So these are the recommendations by the AHA. Next, please. Recommendations are patients who have been successfully resuscitated from sudden cardiac death or have sustained monomorphic VT or non-sustained polymorphic VT should undergo CAD there and then. This is a class 1 indication. Next, please. So now the question comes, if he arrested again, will we be able to thrombolyze him? Should we thrombolyze him? Now, there are various studies like done in of Lancet, NEGM, and American Journal of Cardiology. Next, please. These were the various studies which were published in NEGM. Tenecteplase versus placebo. It was stopped early for futility. In Lancet, they did it with RTPA. They improved the ROSC, but there was no difference in 24-hour survival or survival to discharge. The study which was published in American Journal of Cardiology, it showed it was not statistically significant. So treatment recommendation is fibrinolysis should be considered in adult patients with cardiac arrest with proven or suspected PE, where you have high suspicion of PE. Insufficient data to support or refute the routine use of fibrinolysis from other causes. So it should be done only if the patient has documented PE or very high suspicion of PE. Now, question 6. Suppose patient arrests again. Family wants everything done. Wife is a cardiac nurse. So she asks whether ECMO is an option. What do you tell her? We already know that AHA has incorporated ECMO in its guidelines, where you do eCPR, which is called during CPR insertion of an ECMO, which is a VECMO, which is we know arterial ECMO. So what do you tell the patient? So these are the central and peripheral ECMOs. Central means open heart surgery, and peripheral means where you do peripheral cannulations, one in artery and one in vein. Next. So what is ECMO? It is extracorporeal membrane oxygenation. Extracorporeal means it is outside the body. Membrane oxygenation, that means it is done, oxygenation is done outside the body. So it acts as a CPR bridge to definite treatment and recovery. It is just buying time. There has been tenfold increase in the past few years with high survival rates. Although no RCT till date has been done to compare eCPR with conventional CPR. Now, after 35 minutes of conventional CPR without eCPR, ROSC and favorable neurological outcomes are achieved in less than 1% of patients, which means nearly nil. Now, this is the ELSO registry, which shows that the eCPR patients have been increasing since 1995 to 2015. So a lot of patients, lot of centers are now during their CPR incorporating ECMO in their CPR cases. So timeline should be there. It's not that you have already done it for 2 hours and then you start thinking of it. So arrest to ECMO flow time aim should be less than 60 minutes. Now, in which patients should it be done? In patients where there is a witness bystander CPR, there was a shockable rhythm, no major comorbidities, and when there is failure of conventional CPR to achieve ROSC. So you should immediately shift the patient to an eCPR capable hospital. eCPR means ECMO CPR, where cannulation of ECMO and insertion of the distal perfusion catheter can be immediately done, and immediate investigation and treatment of the suspected arrest, that is angioplasty, can be done if required. In ICU, then post-arrest care, you have to do anticoagulation, you have to monitor for bleeding and thrombotic complications, and you have to await the recovery. Next. So these were the recommendations of AHA. Insufficient evidence to recommend the use of routine eCPR for patients with cardiac arrest, because you have to do it only if you are not able to achieve ROSC with conventional CPR. It may be considered for selected patients as rescue therapy when conventional CPR efforts are failing. And you have skilled providers which can do this eCPR. Next, please. Now, coming to the next question, patient does well, eventually gets discharged to a ward bed, but he suffers again a cardiac arrest. Are there any differences between an in-hospital and out-of-hospital cardiac arrest? Yes, there are a lot of differences. What can be done to improve the outcome of in-hospital cardiac arrest? Next. So, an out-of-hospital cardiac arrest versus in-hospital cardiac arrest. Next, please. So, what were the differences which were noted? Initial rhythm. VF and VT was first monitored rhythm in only 15 to 23% of in-hospital cardiac arrest. In-hospital, out-of-hospital cardiac arrest, VF and VT occurred in 45% of the patients. In-hospital cardiac arrests are most likely because of hypoxemia and hypotension, leading to PEA and asystole. On the other hand, out of hospital are usually precipitated by ischemia. So that is why VF and VT are more common in out of hospital settings. So what can be done to improve the outcome of in-hospital cardiac arrest? Next. Survival. Between 25 and 67% of successfully resuscitated patients, they usually die within 24 hours of return of spontaneous circulation. Now, survival to discharge, it ranges from 0 to 28%, with major studies reporting 20% survival to discharge, which means we lose 80% of the patients. Out of these 20%, 15 to 47 of the patients, they die within first year. So it means in hospital cardiac arrest is a bad prognostic sign. So strategies to improve the outcomes. You have to make teams which initially showed positive effects in reducing both the cardiac arrest and in hospital mortality. Many of these studies were of low quality. So recent meta-analysis showed that there is no effect on mortality despite a reduction in cardiac arrest, even if you are more vigilant or even if you try to avoid. Next. DNR status. What is DNR? Do not resuscitate. although not legal in India, but I'll just be discussing it because it has been there in the international guidelines. CPR may be targeted to those who are more likely to benefit from, because this would be expected to improve survival rate of in-hospital arrest, although no studies have looked at this. Next. So strategies to improve outcomes, ECLS training, where each and every person in hospital is trained for ECLS, that is advanced coronary care. Chest compression rate and depth usually are inadequate in 1/3 of the codes. So chest compression and depth should be taught to each and every person in the hospital, so that whenever there is an in-hospital cardiac arrest, more good quality CPR can be initiated. Next. We'll skip this. Next. This is compression device, which is usually used in foreign countries, but not currently. Very few hospitals in India are doing it. I'll still say hands are the best, so do it more methodically. Next. Not required for them. Skip, please. Early defibrillation. Response time to code teams may be unacceptable long in areas of remote areas. One before-after study showed an improved survival from VTVF from 2.2 to 15.6 after implementation of an AED program, which shows us that there was difficulty in recognition of the rhythm, whether it was a shockable rhythm or a non-shockable rhythm. So with an AED, with the voice prompts, it's more easy to shock the patient and or to see if it is a shockable rhythm or a non-shockable rhythm.